Hello, everyone. Thank you for joining us again for the MIDD Plus 2023 Clinical Track Program. My name is Tom Sun, VP of Strategic Consulting Services at Cognigen Division Simulation Plus. It's my pleasure to introduce my colleague, Dr. Viera Lukacova, our Chief Science Officer at Simulation Plus, as our speaker for the next talk. And the title of her talk is 2023 DDI Standards Model Update. Before we start, we'd like to have a couple housekeeping items. One is that we really keep your privacy rights seriously by attending this conference and participating in the Q&A. You are allowing us to contact you for follow-up. And you can ask any questions using the Q&A tab on your dashboard anytime. If you have any technical question issues, please use the chat tab that our staff will try to help you. So without further ado, we will start the presentation. Thank you very much, Viera.
Thank you, Tom, for the nice introduction, and thank you everybody for joining this session in the clinical track, where we have already covered a number of various topics. And it would not be a clinical session if we didn't talk a little bit about the DDI predictions. So in this presentation, I'm going to cover several different areas. Of course, I'm going to start with a very brief overview, a reminder of what kind of capabilities you have in GastroPlus when it comes to DDI predictions. We'll look into some strategies of how we are developing the standard models that we are able to provide to our users that they can then use for the DDI predictions, show some of those example models as well as some of the published case studies, just as a reminder of what are the different types of applications that you could use the GastroPlus DDI predictions for. So as a reminder, in the GastroPlus DDI module, you can do predictions for the DDIs using the simpler steady state or static type equation, as well as full dynamic simulation when we are simulating both compounds present in the body, where they are meeting in which tissues and how they would be impacting each other. When it comes to the steady state or the static predictions, these are currently incorporated only for the metabolic interactions. We have not included the transporter-based, but it is included for the metabolites, for the metabolism-based interactions. With the dynamic simulations, there is no restriction. It is available for metabolic, transporter-based interactions. You can account for the effect of parent as well as metabolites and so on. And with both types, of course, we are incorporating, or you can account for the three different basic types of interaction: competitive inhibition, time-dependent inhibition, as well as induction. I'm not going to spend too much time on these background slides. This is the type of information, the type of equations we are using. For those of you who have done any steady state or static predictions, you would be familiar with this equation. It is the standard equation for predicting the DDIs, accounting for the impact in the gut, in the liver, and in both locations. We would be looking at possible combination of competitive inhibition, time-dependent inhibition, and induction. So as an information that you would need to provide, of course, if you are using any of our standard models, then the inhibitor parameters or inducer parameters like Ki, inactivation rate, EC50, Emax values for the inducer, as well as the KDEC values for the time-dependent inhibition and induction, those would be coming with standard models that we provide. If you are building your own models, then you would need to provide or incorporate these parameters yourself. When it comes to the effective concentration of the perpetrator, which would be generating the impact, whether it is inhibition or induction in both gut and liver location, we do provide a number of options on how to estimate these parameters. And the more typical ones are the calculations from the standard pharmacokinetic equations, using the systemic average, minimum, maximum concentration, the liver inlet, gut concentration, and so on. But since this is linked to the GastroPlus, where you may already have a model available for at least the perpetrator, you could take this equation or this simple prediction a step further to use the full simulation to actually estimate the effect or to estimate that effective concentration of the perpetrator in either plasma, liver, or the gut. And this would give you more accurate predictions of the concentrations. And it would also allow you to start exploring the time dependency of the effect, because you would be able to look at the impact, let's say, with the first dose of the perpetrator versus the subsequent doses when the perpetrator is already in steady state. So that is sort of a combined approach using the full simulated profile within the framework of the static equation. For the dynamic simulation, this is where the power of this prediction really lies, is running the full dynamic simulations where that impact is captured much more accurately. And again, we are using the standard equations for competitive inhibition, where the inhibitors are impacting the Km value of the victim compound, and time-dependent inhibition or induction, where the perpetrator is impacting the activity of the enzyme or a transporter. It is marked here as an enzyme, but the exact same equation would apply to the transporters, where we are looking at the inactivation of the transporter, induction of the enzyme or transporter, and of course the recovery of the protein, whether it is enzyme or a transporter, once the perpetrator gets removed from the system. Eventually the activity of the protein will come back to the baseline value. So the information that you would need for running these dynamic simulations, of course, the information on the perpetrator remains the same. We still need to provide information on the Ki or IC50 value, inactivation rate constants, EC50 Emax values for the inducers. The difference from the static equation is that for these full dynamic simulations, we need the full PK model for both perpetrator and the victim compound. Within GastroPlus, we allow you to use either compartmental or PBPK models. The only limitation is that you need to use the same type for both perpetrator and the victim. So you would be using compartmental PK for perpetrator and the victim, or use PBPK model for perpetrator and for victim. And of course, the PBPK models, ones that allow you to really account for all different types of interactions incorporating transporters, enzymes. So those are the most flexible and most complete models. And this is where we do help with these predictions by providing the standard models, whether it is models for the standard substrates for the victim compounds or models for the standard perpetrators that you may want to use in predicting the interaction with your compound in your development process. I think I already mentioned this part for the dynamic DDI simulations. Again, there are no restrictions on what kind of interactions you can account for. It can be transporter or metabolism based. It can be happening in any tissue. So it's going to be really looking at the physiological interaction, especially if you are using the full PBPK model. And of course, the compound, the perpetrator, can act as a combination of inhibition and induction as well. To help you with the models so that you don't have to keep rebuilding all of the models yourself, we do provide these standard models, the models that we have already built and validated. We provide them along with the DDI module that you can use for the predictions. And this is a snapshot of some of the models. I think we have still some in the development that are not listed in this table. And these are in various stages of the validation. Some of these models are completed. For some of these, we even have an updated model now. Some of those we do have complete documentation and everything ready for even regulatory application and submissions. And for some of these models, we are still progressing with the validation or completing documentation. So how are we developing these models? How much can you trust the models that we provide to you as the standard models, whether they are substrates or perpetrators? We do use a very rigorous approach of collecting information that we can find in the literature up to the date of building the models. And this is also the reason why we are now rebuilding some of the models, because some of these we've been building about 10 years ago. Of course, over 10 years, new information came out or was published in the literature about those compounds. So we've started rebuilding some of those models where there is initial additional information, just to make sure that we are incorporating all the information about the compound, everything that is available, and provide the model as good as it possibly can be. And as we are building the models, of course, the first step is build a model that describes the PK of the compound itself. Then we validate the model for predicting DDI, and finally compile all of that process, all of that information into a report that contains information about how the model was built, how it was validated, all the information that a reviewer would need to see if the model is accurate, how much they can trust the model if you use it for, let's say, regulatory application. A little bit more detail on this development process. I'm not going to spend too much time. I think I have a couple more slides, but these next 3 slides I'm taking or borrowing from Mike Bolger's presentation. Mike Bolger, our founding scientist, have given a very nice and very detailed presentation 2 years ago on the entire process of the development that you can find on our resource website. So for those who are interested in additional details, I would recommend that. This is just to show or highlight that the models that we are building, we really follow a very rigorous approach, making sure that the information is accurate, is correct, and when the model is finally released for your use, it is validated and it is really accurate model to use. This is an example of one of those models for Fibrozil. For those of you who may not be familiar with the compound, Fibrozil is mainly eliminated by metabolism to Fibrozil glucuronide, and the glucuronide acts as a time-dependent inhibitor of 2C8. However, and that was the initial reason for building this model, but of course we've dug a little bit more into the information about these compounds. They are also inhibitors of additional enzymes and transporters. So all of those mechanisms we are now revalidating and incorporating. So to start with the model building, we do start with the in silico evaluation, collecting all the information, whether predicted from the structure or collecting the properties from the literature, utilizing our ADMET predictor transporter predictions to help us evaluate or make some educated guesses about what transporters might be involved in these compounds, PK, as well as looking at the potential clearance mechanisms. Are there any potential issues that we might need to be looking into? And specifically for Fibrozil, reviewing the information on the properties, on potential involvement with the enzymes and transporters, we came up with a list of points to keep in mind as we are building the models. Right? Looking at whether solubility or permeability may be an issue, what kind of clearance mechanisms we need to pay attention to. The transporters might be important for the PK of the compound, and so on. Once that was completed, then of course we build the models incorporating all of the relevant mechanisms for both the parent compound as well as for metabolite, and build a model that is validated to describe the PK of both compounds from as many studies as we can find in the literature. And here I'm showing only 2 studies for 2 different dose levels, 300 and 900 milligram dose, showing both Fibrozil, the red points and line, and the glucuronide metabolites shown in blue. But there were a number of additional studies, other dose levels, and so on, that we used to validate the PK and to really give us is able to capture the PK of both compounds. And once that was completed, then we used the model to validate the DDI predictions. And this is again showing one of the examples that we used for the validation. It was a study with rosiglitazone, which was administered about 1 hour after Fibrozil BID dosing on day 3. The top plot is showing the prediction for the rosiglitazone administered alone. And the bottom plot is showing the prediction, the red line, for rosiglitazone administered after the Fibrozil pretreatment. And to make it easier to evaluate the change in the PK, the observed data are showing both. The lower profile is showing the observed data from the placebo arm, and the upper profile is showing the data from the co-administration with the Fibrozil. And quantitatively, of course, we are also comparing the predicted DDI ratio on Cmax as well as AUC with the observed ratio. And as you can see for this one, it came very close. It can hardly come any closer when it comes to the predicted DDI. But when it comes to the quality of the prediction, the criteria that we use is the one published by Alan Guest a few years ago, about 10 years ago, where they proposed that instead of using the 2-fold limit for the DDI prediction, we should be using the limits of that scale with the impact of DDI effect, so that for the cases where the DDI is fairly small, even the tolerance on the error will be lower, versus the cases where the DDI is already very high, the 2-fold error tolerance should be accepted. So those are the criteria that we are using to evaluate or to verify the quality of the DDI predictions with our models. And finally, we do have a report. Of course, I'm not going to go through a complete report. It's just showing a snapshot from the first couple of pages for one of these models, showing that they would be ready in the format available for submission to the regulatory agencies. So let's take a look at some of these models. Of course, rifampicin, one of the popular models lately. It is a 3A4 inducer, but it does have other interactions as well, inhibitor and inducer of other enzymes and transporters. So the model that we've been rebuilding about 2 years ago is now being validated for the additional impact or the additional DDIs. In here, we are showing the first step, validating the PK. And again, taking variety of studies, and here I'm showing only a few of those, the IV data, couple of different oral doses, making sure that the model is able to account for PK across different dose regimens, different formulations, as well as for the potential impact of autoinduction or autoinhibition, which of course with the rifampicin, the autoinduction is something that we need to account for. Once the PK was ready, we validated the model for the DDIs. And in this case, we have version 2 of the rifampicin model. And I'm showing here the performance with the guest criteria, the black dotted lines showing the target criteria that we are trying to fit our predictions within. You can see that the first model that we had, that we built maybe 10 years ago, versus the rebuilt model, which was completed about 2 years ago. The performance of both models are, when it comes to 3A4 mediated DDI, is very similar. So even the original model was already very good in terms of 3A4 induction prediction. However, the new information that we were able to collect on rifampicin since the previous model building does allow us to incorporate additional mechanisms and allow us to look into the impact of rifampicin on not only 3A4, but also other enzymes as well as transporters. So that is the main strategy with some of these models, allow us to extend its impact and account for other DDIs. As long as I have this slide on here, one thing to keep in mind when you are validating or even using these models to, let's say, validate your own model that you might be building for your own substrate, is keep in mind the inter-study variability. And the studies that I've highlighted here are studies with rifampicin and midazolam, where similar doses of midazolam were administered 12 or 13 hours after rifampicin dosing on day 5 or 6. So based on the study design, all of these should have produced very similar DDI effect. And yet you can see that there is an effect of nearly tenfold difference between some of those studies. So keep that in mind when you use this model to verify whether your model that you might be building for your own substrate is accurate. It may not always lie on that green line because of the inter-study variability. Itraconazole, this is just showing performance of our itraconazole model with the different midazolam studies, data in blue, calculated with red. Again, you can see very good performance. I'm going to have to speed up here a little bit, so I'm going to go a little bit faster through some of these other models. I think you already do have an idea. This is for diltiazem, a competitive and time-dependent inhibitor of 3A4, where we needed to account for both parent compound as well as one of its metabolites as being the competitive and time-dependent inhibitor. So the model building the PK had to incorporate autoinhibition. And once we had the model, then we verified it by predicting DDI with different substrates. And in this case, we used midazolam, triazolam, quinidine. And the top plots are showing the placebo arms where the substrates were administered alone. And the bottom ones are where they were administered with diltiazem. And again, you can see the model did a very nice job predicting all of these different DDIs. It's not all on about 3A4, so I'm going to show only a few examples for other types of models that we, of course, have. This one is dolutegravir that was originally built as a substrate for UGT1A1 interactions. This is for metformin, which, of course, was built as OCT2 made 2 substrate, so for transporter-mediated DDIs. And actually, we were able to study on DDI between metformin and dolutegravir. So the model that we have built here to describe the PK and serve as a UGT1A1 substrate is now also available or could be used for prediction of DDI as an OCT2 inhibitor. It was validated with the metformin. And another transporter-based for rosuvastatin for OATP1B1, 1B3. Again, model initially built to describe the PK correctly for different doses. And then it was validated by predicting the DDI with gemfibrozil. But gemfibrozil would be also inhibitor of OATP. So, of course, we have a number of additional models, as you have seen in the table. We would be sitting here probably for 3 days if we had to go through the details of every single model. But this is just to show you that we are building models for a variety of mechanisms and how they are impacting or how we are validating or verifying the model performance. Some of the case studies, and again, I'll go through some of these quite quickly. This was one of the publications from about 2 years ago, where this group built a model for oxycodone in GastroPlus, and actually looked at the oxycodone as well as 3 of its metabolites. So it was a fairly complex model, and they validated the model by predicting both the AUC and Cmax values for the parent compound, as well as those three metabolites after IV and PO administration. And you can see that overall the model did a reasonable job describing the PK of all four compounds. So then they used the model to predict the DDIs or verify the contributions of the enzymes, the 2D6, 3A4, to the metabolism of these four compounds by predicting DDIs with different perpetrators. These are a couple of examples from transporter-mediated DDIs. These were used in regulatory submissions. The top one was for a potential BCRP inhibitor, the bottom ones for a PGP inhibitor. One of these was submitted and accepted by an EMA. The other one was submitted and accepted by the FDA. The part I'd like to highlight here is that building the models and doing the DDI predictions does not necessarily have to be a daunting task. The part that was really nice with this example is the company simply stated, we already had the model for a different purpose, so simply using it for the DDI prediction was a very easy task, required minimal work. And that is how you really should be using the models. You are starting to build the models in the early stages, so just continue using the model for additional applications as you keep improving it. This is another case study that was published a few years ago on a ruxolitinib built as and verified or used as an inhibitor for PGP as well. Of course, it's not only our customers, it's also our consulting team that is very busy with the DDI projects, with the DDI studies. And this is a snapshot of some of the DDI projects over the last 12 months or so, maybe 18, where, of course, most of the studies still are for the 3A4, very popular category, predicting the 3A4-mediated DDIs, but it is not only 3A4. The pH-dependent or PPI acid-reducing agents, different type of DDIs, but also transporter-mediated OATP, PGP, BCRP, or other CYP enzymes. These are the types of the studies that are being done, that our consulting team has done, just to highlight that the different types of DDIs can be predicted and are being utilized either by our clients or by our consulting team as well. So to sum this up, just one quick point. The GastroPlus models are used to simulate complex DDIs for both internal decision making as well as regulatory applications. And the model files that we are providing, we are now providing also written documentation. So they are ready also for submission for regulatory review and applications.